Hello, everyone. We are gathered here for the inaugural episode of the live stream TMD Demystified. I am Tony Urbanek. I hope those that join us, the purpose of this is I hope those who join us learn something that they can utilize regarding the problem, the disease, better known as TMJ, but accurately known as temporomandibular joint disorder. You may not be new to TMD Demystified, since I have a ongoing podcast on YouTube and also published several other areas, including Dental Town. I am now have actually published 245 podcasts entitled TMD Demystified, covering every aspect of the disorder that I can think of or can think that other people may benefit by knowing this information. And I also uh, have a blog, which I do an article once a week, and we're now up to 178 articles, which are published in our network of uh, providers and also other areas, patients, which is easily seen at our website at urbanictmj.com, www.urbanictmj.com. But the purpose of this live stream is to give others an opportunity to comment or ask questions on the problem, on the disease. I don't want to um, go over each and every item necessarily in the already published podcast. The purpose of this episode and the inaugural episode and episodes to follow, hopefully once a week, will be to invite guests to ask questions, to comment, so that they can actually find out directly what I already know about temporomandibular joint disorder. A little background for me, for those who are not introduced, very quickly, I am an oral maxillofacial surgeon, trained both in dentistry and medicine, and academic degrees, medical degree from Vanderbilt, dental degree from Indiana University, master's degree in cell biology and anatomy from Indiana University, 2 years as a fellow with the National Institute of Health, National Institute of Dental and Craniofacial Research on facial growth and development. That's the quick and easy way to describe what my training has been. And my focus for my career has been major facial reconstruction of various kinds, including 2,000 temporomandibular joint surgical cases. But approximately 15 years ago, after 2,000 TMJ surgeries over the first 36 years of my career, I decided that temporomandibular joint surgery was not going to be a long-term effective treatment for the problem of temporomandibular joint disease, and began a research quest to see if I could figure out exactly, precisely, why it was such a conundrum in dentistry, why no one really had a handle on how this disease operates. And this is true. In my career, it was very obvious that the problem was given to the general dentist to solve. And the general dentist, or dentists being trained in dental schools, had no way to literally understand the problem, because they were taught from the beginning that this joint is different. The temporomandibular joint is different than any other joint in the body, which is not a true statement. This is part of the discovery that I made, discoveries, plural. But to make it clear, the discoveries that I encountered had nothing to do with whole cloth discoveries. Everything that I encountered, which eventually led to the proper understanding of the disease, was already published, is already in the literature, in the scientific literature, in the peer-reviewed literature for some of it for over 70 years. So I took upon myself to do this research project because of my broad background in academics and clinical activity, because I was a practicing private practice oral and maxillofacial surgeon doing multiple types of facial reconstruction. Only a portion of that was temporomandibular joint surgery, but a large portion, 2,000 operated cases, half of them open joint, where an incision is made in front of the ear, go inside the joint, and half of them through an arthroscope, which is acceptable technical way of operating some of these temporomandibular joint problems. And but when I decided after 36 years of doing this, that temporomandibular joint surgery was not a long-term solution, because patients would be back. In my practice, a third of the patients would be back within a year or two with the same symptoms on the same side that they entered with. And in type of practice that I had, I was used to telling a patient exactly what they could expect, whether I was doing facial reconstruction, orthognathic surgery, microneural surgery, cleft palate surgery, cancer reconstruction surgery. I was used to being able to tell a patient exactly what was going to happen, exactly what they could expect, pretty much exactly how long it was going to take. And when it came to temporomandibular joint problems, a third of the patients would be back within a year or two, sometimes less, sometimes 6 months, and they would present with the same symptoms. Now, that doesn't mean that all of the patients were like that, and their surgery has had some value, because 2/3 of the patients were doing well. In fact, to this day, I have a large file of patients who come to see me who are operated on one side and now have the same symptoms on the contralateral or opposite side. So it proves the point that it isn't the point that there's absolutely no value in surgery, but it is totally unpredictable, frankly, in my experience. So when I began doing this research, I started with the patients. I started asking the appropriate questions with the patients. What makes it better? What makes it worse? I had a long line of patients who had this problem that came into me for a solution, thinking it was probably going to be a surgical solution. And instead of bringing them in and sitting down with them and doing an examination, verifying they had TMD, and telling them what type of surgery I was going to do based on what the literature in surgery says to do, my colleagues, the textbooks, the congresses, the meetings, this is how you do surgery on the temporomandibular joint. I was well versed on that, and I did every type of possible temporomandibular joint surgery. Some I did a lot more than others. However, in doing the research, I brought patients in and I began to just ask them the basic questions. What do you think about the problem? What can you tell me about the problem? Talk about the symptoms. Define the symptoms in your own words. What makes it better? What makes it worse? What does your husband think about it? What type of weather are you having? Does the dog bark when it hurts? What phase of the moon is it when it hurts? What other unusual symptoms that I'm not aware of that you're having that might be associated with your problem that everyone calls TMJ? And out of the first 24 women, because this problem is primarily females, it's 90% females, 10% males. The first Out of the first 24, roughly 12 of them said, if I take my finger, a pencil eraser, my tongue, a piece of cloth, and gently put it between my front teeth, it feels better. After hearing that a dozen times, I went into my little laboratory where I used to make devices that went intraorally for putting somebody's face back together, one way or another. And I made a device that did nothing more, nothing less than what the patients indicated, gave them some assistance, help. And I gave the first one I made to a woman who had 15, 20 years of headache, earache, jaw pain, neck pain. And I said, put this in your mouth, leave it in 24/7, except when you eat. I designed it so they could breathe, so she could breathe with it, so she could talk with it in her mouth. She could drink liquids with it in her mouth, but she just couldn't chew with it in her mouth. It basically only the front 6 anterior incisors and canines touched, and the posterior teeth were disoccluded, didn't touch. And I asked her to put it in her mouth, come back in 3 weeks, keep it in 24/7 except when you eat. And she did. She came back in 3 weeks. I walked in the room and I said, "How you doing?" And she said, "Thanks, doc. My pain is gone. My pain is gone." And this was a woman who had 20 years of headache, earache, jaw pain, neck pain. And that is how this whole thing started 15 years ago. So my purpose, I'm on a mission. I'm on a mission. I'm on a mission because we know now that if you attack this problem correctly, you will get the results. And how to tackle it correctly is what the purpose of this live stream is. And also the main purpose is to allow others who want to participate and ask questions or even criticize or fact check me. As to my information, I am happy I make myself available. That is what I'm doing. I'm making myself available to both the professions, both the dental profession and other professions, if interested, and certainly the public, primarily the public. I am primarily interested in making this available to the millions of women who have this problem of various degrees over various time periods, but it is an extremely problematic problem. It is extremely difficult for patients to get good, effective, and I emphasize effective, information about this problem. In my experience, which is vast, after doing treating non-surgically personally well over 5,000 patients, my practice and colleague has, because of others doing this, both in the practice and now a network of providers who are licensed to use this technology that I have developed. They have to have a license to do it because the device involved is patented. But we have treated well over 10,000 people successfully. And the information is there. Technically, there is a university study that has been done and proves statistically how effective it is to use a device that separates the posterior teeth according to a protocol. Protocol is very simple. That had to be worked out. How do you use this device? And you must use it according to the protocol to use it safely, to not create other unintended consequences. But the protocol is pretty simple: to keep it in your mouth 24/7, except when you eat, chew for the first 2 months, and then nighttime only indefinitely, the rest of your life. And that handles the vast, vast majority of patients. Everything is on a bell curve, as the scientists involved here know. The majority of people fit in the middle of the curve, and then there's the two tails of a curve that a few people don't fit in the middle of the curve, statistically. But the statistics are 85% of patients nighttime only, all they have to do for the rest of their life. And then there are about 15% that come in and tell us, I figured out I need to wear it when I'm in traffic. I need to wear it when I'm sitting on the computer. And those are the times when patients tend to clench or grind. And clenching and grinding is not the only cause of TMD, by the way. For those who are married to that idea, that is not a truthful statement. That is not a statement that holds water. There are two other causes, which are acute trauma, and the big one that most people either don't know about or ignore is functional malocclusion. When your teeth don't fit together to the point where they overload the joint, and that is what all three of the causes, there are only 3 causes of temporomandibular joint disease. There are only 3. that cause damage to the joint. You cannot have temporomandibular joint disease unless you have damage to the temporomandibular joint. And there are only three methods, or if you want to call them causes, methods, to damage the temporomandibular joint. The most common and well accepted by the public and the professionals is clenching or grinding the teeth. Too much repetition on a joint, any joint, will cause eventually damage to that joint. Goes along with jogger's knee, tennis elbow, and temporomandibular joint disease. In fact, I'll throw this one out just at the beginning of our very first live stream. Tennis elbow and TMD, temporomandibular joint disorder, are identical diseases, just different joints. And I will explain that shortly. And then the second method to damage temporomandibular joint is also an obvious method, which is acute trauma to the face and the jaws, either directly on the joint itself, or more likely trauma to the lower jaw to the degree that the forces are transmitted backward or upward into the joint and damaging the inside of the temporomandibular joint. And then the third method to damage the temporomandibular joint is functional malocclusion. Now, malocclusion is it's not a catch-all phrase, but it is a broad statement that doesn't really describe the different types of malocclusion. You can categorize them in different ways, but the two categories that I would like to use are aesthetic and functional. Now, a lot of people are interested in how their teeth look, and that's fine. And if your teeth are not aligned properly so that you can see them, and you want them aligned properly, then you go to a dentist or orthodontist, general dentist who does orthodontist, or a specialist who does orthodontics, and ask them to straighten your teeth, align your teeth aesthetically. And then there are functional malocclusions. Now, functional malocclusions actually are very, very common. Functional malocclusions, I do not have that number at hand, but a significant number of people in our population in the United States and worldwide have bites or occlusions. Occlusion is nothing more than a descriptive term for how your teeth fit together. Have a bite in such a way that it overloads the joint, just like bruxism overloads the joint or acute trauma overloads the joint. And what they have in common, all three of those things have in common, is they damage the temporomandibular joint. Now, once you get damage in the body, whether it be in a joint or on the skin or in an internal organ of any kind, the response to that damage is called inflammation. Inflammation is the body's response to damage. Inflammation is the body's attempt to heal itself. Amazing structure that we live in, this thing called the body. Amazing. It has tremendous abilities. And as I've said on many other occasions, good doctors understand and know and operate from the fact that we hardly do anything to help a patient in comparison to what the body is doing. We're just here. A good doctor understands, whether he is a surgeon or a medical doctor or a dentist or any other kind of doctor, chiropractor, that the point is we do the things to help the body to get to the point where it can heal itself. And that is what inflammation is. And as a trained, degreed doctor with also a degree in cell biology and gross anatomy, I am well versed. I'm skilled at understanding how inflammation operates. But on that hand, I have to admit, and anyone who actually researches in the area of inflammation, there is a lot we know about inflammation and there's a lot we don't know. But there is a lot more coming out right now, and I am attuned to inflammation on a daily, weekly basis as I read my topics. But as it applies to the temporomandibular joint, now we're at the point where the joint is inflamed, it is damaged, And that is where the train got off the rails with dentistry. That is where the train got off the rails in the dental schools, who taught that this joint is different. This joint is unique. This joint operates unlike any other joint in the body. Well, that doesn't hold water. That is just not factual. Temporomandibular joint operates just like all the other joints in the body. When you talk about the neurology, the histology, when you talk about how this joint responds to damage, just like any other joint in the body, and how it responds has been in the literature since 1906. And if the orthopedic surgeons who operate on and are asked to make judgments on the health or unhealth of all the other joints in the body, if the orthopedic surgeons had been left with this joint in their area of expertise and excluded, basically the orthopedic surgeons didn't want anything to do with this particular joint. It's the only joint in the body that they don't want anything to do with. And the reason for that is this joint is connected to the jaw, which is connected to the teeth. And when it was got to be connected to the teeth, the orthopedic surgeon says, this is not my area. I don't know anything about teeth. So it was put in the lap of the dental industry, the dental profession, to figure out what to do about problems with this joint. And that's where it went off the rails. And that's where, to this very day, this very moment, every dental school in the United States of America, I am certain, because I have done those questions to the universities, they all teach that this joint is different. And all the dentists I have talked to, and that has been thousands, have agreed. They are taught that this joint is different. It's unique. And you can't possibly fix this problem if you think it's different. So, what I want to then go into now is just a brief explanation and overview of the basics of what I discovered, and then I'll just leave it open to anyone who wants to ask me a question. One point, I cannot give medical advice on a live stream. I don't want to give medical advice. I can't diagnose, and I can't tell you as a individual, if you are a patient, what you should do. I can tell you where you can go. I can tell you how you can find the person who can help you, unless you live somewhere in Middle Tennessee, at which you can come see our practice. But this is a national problem. It's an American problem. It's a worldwide problem. And I want to make this information available to as many of the millions of women, 90% females, 10% males. It's a female problem for this one fact that has been in the literature now for 70 years. Estrogen exacerbates inflammation. We have gotten to the point in my discussion here this morning or this afternoon, depending on where you are, that inflammation actually drives the symptoms. Inflammation creates the symptoms. But inflammation needs to be understood as to how it works. So for those who are with us, let me go through a brief description here of what you need to know about what I discovered. So I just shared my screen with you. This is, if you're a patient, don't be intimidated by this little cartoon diagram. If you are a doctor, you should be very familiar with what I'm showing you. But here is the discovery that has been in the literature and known by the orthopedic surgeons for the better part of 50 years. In fact, part of my discovery after interviewing 24, 25 patients and them telling me they get benefit by putting something between their front teeth over a period of time, this information has been in the literature and easily to understand from the dental and medical profession. So basically, here's a cartoon of the different levels of the brain, and here is a cartoon or diagram of a temporomandibular joint, which is here. The muscles that move the joint, you don't need to necessarily know the names of them, but these are the muscles that move the joint of the jaw. This is the area of the joint itself, but when a joint, here is the problem. Due to either bruxism, which is clenching or grinding, or acute trauma transferred through the jaw into the joint, or functional malocclusion, where your teeth don't fit together to the point where it overloads the joint. That's what all three of those methods do. They overload the joint, they cause damage, they cause inflammation. A signal is sent. This is the issue which is unknown in dentistry. The signal is sent to the brain, an area called the trigeminal sensory nucleus, which goes to the next area, to the motor nucleus. These are nucleuses where the origin of a nerve sensation or a nerve action is done. So it's called a nucleus, and then it goes to the spinal trigeminal nucleus, and from there it goes back to the muscles that move the affected joint. In this case, the muscles that move the jaw joint, the TMJ, where the damage is done, in a protective method. This is a protective method. Again, acknowledged, known, understood, and promoted by orthopedic surgeons for well over 50 years. They know all about it when it comes to hips, elbows, and knees. The dentists do not apply this information. So the point is that when this signal is given to the muscles that move a joint, they get tight. And where the muscles are attached to the other areas of the bone, in this case, areas of the bones of the face, which can occur in the upper headache, the midface, frequently confused with sinus problems, sinus pain, or low face, mandible, even neck pain. Patients complain of various pains around the head and the neck. When the problem is not solved over a period of time, these signals keep being given off from the joint. I'm inflamed, ending up in the brain, telling the brain I'm continuing after 2 weeks, after 2 months, after 20 years. These signals continue to get into the brain, the nuclei going through the stages and back out saying, tighten up, tighten up. The signal then expands into tightening up the whole head. And the second most common symptom of TMD, is upper back and shoulder pain and tightness. And beyond that, the signals go out and say the upper shoulder girdle needs to be tightened. Tighten up from the upper shoulder girdle to the neck, to the head, to the jaw joints and all the muscles that move the jaw joint, the facial muscles, the muscles of mastication. And patients complain of some of or all of the following symptoms: frequent and or recurring headache, earache, jaw pain, neck pain, ringing in the ears, feeling of fullness in the ears, which is called subjective hearing loss, vertigo, dizziness, upper back and shoulder pain and tightness, often described as tightness rather than pain, and arm, hand, finger tingling and numbness and various kinds of jaw locking. So that is the technical description. Now, for those of the professions, especially the dental profession, that is following us along today, I'd like to share, if I can move along to this particular slide, and I'll share that with the viewers, just to prove the point that this is not new information. The mechanism that I just described is well known. And let me see if I can enlarge this a little bit. That's better. Reflex, it's basically called the reflex muscle splinting in joint inflammation. This is established physiology. This is in the basic scientific literature. It's a protective neuromuscular response to joint inflammation, and well documented for over a century, with the foundational study that goes back to 1906 by a Dr. Sherrington, entitled Integrative Action of the Nervous System, Yale University Press, 1906. That is the first article that I could find that describes this mechanism, which has been totally ignored by the dental profession. And of course, there are many more recent, from the joint physiology literature. This is just orthopedic joint physiology literature. Hurley, article by Hurley in 1997, article by Hopkins and Ingersoll in Sports Rehabilitation in 2000, in the trigeminal TMJ Neurophysics, article by Cecil, two articles by Cecil in the Journal of Oral Rehabilitation, Journal of Oral Rehabilitation, one in 2004 and one in 2006. And then a specific article on the specific reflex evidence from Wang and Art and Nielsen and Severson in the Journal of Orofacial Pain in 2004. But if you go into a dentist today in 2026 and say, I think I have jaw joint problems, I think I have TMJ, I think I have TMD, 50% of dentists will make a night guard and give you a night guard and tell you that that is the solution for your temporomandibular joint problem. All right, so I've made my point and spent a little over 30 minutes making it on our inaugural event here, live stream today. I would just like to see if there's anyone who would like to make a comment or ask a question. Happy to answer questions. I'm here to answer questions and get in communication through the live stream chat network, or respond to your criticism if you'd like. I can do that also, but I'm well versed on this information. So at this point in time, I see some comments here, which thank you very much. I understand for this one particular person how much this problem has devastated your life. The pain is so bad. Yes, I'm very familiar with that. So if I'll wait a minute and see if there are anyone who actually would like to ask me a question. Or make a comment. I'll be happy to respond to that. And then we'll wrap it up for today, and see what happens. All right, we have a question here. Happy to answer. Let's see what it says. What are the common routines physicians employ to combat joint inflammation? Well, I guess it depends on the kind of physician you're talking about. Whether you're talking about your PCP or you're talking about a specialist. I am familiar with all of them. I am a physician. I know my colleagues very well. I trained at Vanderbilt. I did my oral and maxillofacial surgery residency at Vanderbilt and rotated through most of the specialties within the medical system. So let's just start with the most obvious, your PCP, what he likely to do first of all, if they recognize that if the physician recognizes it's a TMJ problem, he's going to say, go see your dentist 100% of the time, 100% of the time. And he'll punt. He don't want anything to do with it because he knows he thinks that the dentists know what to do. And now he's wrong, but he doesn't, he thinks they do. If he doesn't think TMD, if he's just operating on symptoms, if you say, I have these symptoms, and I outlined the 10 most common symptoms. There are a few others that I didn't outline, but if you just take the common symptoms, the most common symptoms are headache, earache, jaw pain, neck pain. Neck pain, the second most common symptom, but you also get the non-painful symptoms, which are ringing in the ears, subjective hearing loss, and vertigo. Those three symptoms work through a separate mechanism, a totally separate mechanism that allows the inflammation in the joint to get into the middle ear. I did not describe that today. I don't have time to do that, but that is also a well-known mechanism that has been in the literature. That mechanism has been in the scientific literature, and literally in Gray's Anatomy uh, for since 1680. Since 1680. All right, to go back to the question, it stimulates a lot of information here. So the physician, if he doesn't think it's TMD problem, um, he's stumped, and he will treat symptoms with, if it's PCP, he's going to treat symptoms with drugs. He's going to give you pain medicine, he's going to give you neuroleptics, or he's going to say you're crazy, because I have had many, not just a few. I've had many patients come in and say, my physician, my doctor thinks I'm crazy because these symptoms are so disparate. Disparate, meaning they're various, and they don't make any sense to the physicians. I could tell a story about being in Vanderbilt Medical School, and my dean asked me to talk to my class about what my class needed to know about dentistry, but he gave me 1 hour to do it. How are you going to teach a bunch of medical students about dentistry in an hour? Any case, so common routines for physicians. If you're a walk-in clinic nurse practitioner or nurse practitioner, they're going to misdiagnose it as ear infections. They're going to misdiagnose it as migraine headaches. They're going to misdiagnose it as Meniere's disease. If you have Meniere's disease, ringing, fullness, dizziness, that is what Meniere's disease is. That's the way you diagnose Meniere's disease, is have one or more of those symptoms: ringing in the ears, fullness in the ears, dizziness. If you are an ENT surgeon, that is the kind of doctor you go to see with those three symptoms. And the ENT does a very expensive workup, and the patient says, oh my God, now we know what it is. It's Meniere's disease. And the ENT surgeon says, we do not have any solution for Meniere's disease, but we know. I am certain, in fact, dentists who actually see patients with TMD, they don't know what to do about it, but they are well familiar with ringing in the ears, subjective hearing loss, fullness in the ears, and dizziness are well established, agreed upon symptoms of TMD, and the solution is get rid of the inflammation in the temporomandibular joint. And then the neurologist is another category that you might see with some of these symptoms. And the most common thing that they do nowadays, as I am finding out, is they have they have traversed into the arena of using botulinum toxin A, better known as Botox, which is a method to paralyze muscles. Of course, if you have a tight muscle and it's pulling on the bone, it creates the pain. A muscle pulling on bone creates the receptors, they're called nociceptors, that are attached to the bone, attached to the muscle. When the muscle gets tight, it pulls on the bone, stimulates the nociceptors. Nociceptor is Latin for pain receptors. Doctors can't talk in English, they have to talk in Latin. So we call them nociceptors. And that's what creates the pain, the nociceptors. Again, it's basic histology. This is not rocket science. But the neurologist frequently nowadays, along with a lot of dentists and other practitioners, are being sold this concept of using Botox, which has to be repeated every 3 to 4 months at worst. or at best, and extremely expensive and only localized. If you have a pain here, it'll paralyze the muscle, and that muscle will not work. So you won't have the pain until Botox wears off, and then you have to have it on again, have to do it again. But what about the ringing, fullness, or dizziness? What about the upper shoulder pain or tightness? What about the headaches that you have up here? So anyway, the neurologists now are, I am finding out, are going the dark side and using this very expensive drug, botulinum toxin A, which has to be repeated. I have a patient, and she swears to me, and she promised I would bring you in the receipts over 10 years that I and my insurance company spent over $200,000 over 10 years. That's $20,000 a year on Botox. Sitting in my office in my examining room with the same symptoms she started out 10 years prior. And I just had a recent one that didn't have that large a number. Her number was $2,500 a month. Repeated, $2,500 a month on Botox. It's treating symptoms. Drugs do nothing more than treat symptoms. They don't address the problem. There is a drug that works really well on inflammation. Aspirin works really well. Ibuprofen works really well. The problem with non-steroidal anti-inflammatories is they have a very, very short effective life, and then they run out of steam, and everybody knows this. In fact, it proves the point. Non-steroidals, and the most common ones are literally aspirin and ibuprofen, Motrin, are very effective, but only for a very short period of time. And then when you go beyond where you should be using it only intermittently or for a short period of time, you can significantly damage your liver and kidneys. In fact, I've had a one of each where patients were put on the replacement list, liver replacement list, because they damaged their liver and so severely by taking non-steroidals because of long-term 10, 20 years of constant nagging. I can't stand it anymore. I understand that. I'm empathetic. I can't stand it anymore. Temporomandibular joint pain. I hope I answered that question. Let's see if anyone else has anything to say. Ask what treatments options are effective. Well, I'm not sure whether you're familiar with the Urbanic device and protocol. This is what I established. Once I determined what the cause was, what the pathophysiology was, what's the sequence of events that occurred when it came to creating the disease, it became obvious. I told the story earlier today, how unloading the joint with a device over a period of time, short period of time, according to a protocol, will unload the joint, allowing the joint to heal. See, that the inflammation will go down by itself if you unload the joint enough over a period of time. And that is why a device that does this, I do not have, and I actually I should have brought one of these things into the studio today. But the backdrop, if you can, let me see here. You can get a picture of the little device. We used to make them out of acrylic. Now we make them out of resin. Sits in the upper part of the jaw, separating the posterior teeth. That's what you're looking at here in the backdrop. I guess I do have a device. It's the backdrop that my staff made for me. But you have to wear it accordingly. It has to be delivered by a doctor who understands what the mechanism is. We now have doctors in 18 states who are doing this. You have to be licensed to do it because the device itself is patented, FDA cleared. Individual study done on it by Middle Tennessee State University, statistically proving the statistics. And those doctors the doctors throughout the United States who are licensed to do this can be found on our website, www.urbanek, U-R-B-A-N-E-K, urbanektmj.com. And the doctors who throughout the different parts of the United States who are licensed to do this, happy to help you. We're happy to help you if you live in Middle Tennessee. We get patients from all over the place, and I just don't like to see patients coming in from out of state. Oh, we get patients from Kentucky and Alabama all the time, or both ends of Tennessee fairly frequently. But when they're coming in from Texas and Louisiana and Idaho, what I would suggest is you get your dentist or find a dentist who actually wants to find a solution for this problem, learn how to do it, apply it to their practice, and apply it to you. That's what I would suggest if you want actually treatment. And I'd suggest you do that. I understand how problematic these symptoms are. They ruin patients' lives for sure. The other, if you ask me what are the options, you can treat symptoms. You can treat symptoms short term if it's localized with Botox. Drugs are not effective, whether it be neuroleptics. Patients give doctors, physicians give all kind of drugs. Do it. Surgery, if you have been watching since the beginning, I am a surgeon and I elected not to continue doing surgery after the first 36 years of doing over 2,000 temporomandibular joint cases. I elected to do the research to find out really what was going on about this problem. But all of this information and a whole lot more can be seen at our website, www.urbanektmj.com. All right. Are there any other comments or questions that I can do for today? We've been at it for almost 50 minutes now. I don't want to go beyond an hour. I appreciate those who have been with us today. And the plan is to do this every Saturday at 12 noon Central Time. I pick Central. That would be 1 o'clock Eastern. It would be 11 o'clock Mountain and 10 o'clock Pacific Time. For those who really want to learn about this problem, be directed, first of all, learn about it, get the correct information. And again, it's because it's live stream, I'd much prefer just answering a question and then applying what I know to that question, which both questions today were extremely important and directed to the information that patients need to know. I am doing this for the patients. And I am encouraging patients who have this problem and have run around in circles. Literally, the majority of patients I see have been run around in circles, many for decades. Most of them, at least for a year or two, many of them for decades. And I have multiple people over that list of 5,000 plus who have had these problems for 30 or 40 years and don't know what to do about it. And it gets worse over time. As if you have the problem, you already know that. It gets worse over time. Symptoms get worse over time. You start picking up more symptoms over time. You may start with one symptom, and then you'll pick up a second symptom, and the symptoms always get worse. They cycle. The body spots the inflammation, drives it down for a short period of time, then it comes back, only hurts more, stays longer, goes away for a while, comes back, hurts more, stays longer, and eventually you get to the point where it doesn't cycle anymore, and it's just all the time. The symptom gets worse and worse and worse, and they just go out, but the cycling stops. But for the first few years, if not decades, it's always cycling, and then you get to the point where it doesn't even cycle anymore. It's just constant misery. This is what I observe. This is what I've seen. This is what I've seen over 50 years treating this problem, first surgically and then non-surgically for the past 15 years. All right, with that being said, I encourage you to come back next week with questions, comments, even criticisms. I'm happy to, if you have a criticism about what I have to say, I'll be happy to respond. Not a problem at all. I hope to see you again. I hope this helps. I am here to help the patients because I know how big a problem this is. I've seen it for too long. So I am Tony Urbanek. This is TMD Mystified, and I hope you have a happy Saturday. This is Easter weekend. I hope you have a wonderful Easter, and hopefully I will see you